All right, well, hello and welcome back everyone to another edition of the Fellow Project Lecture Series. Today's edition is focused on perioperative pearls in bariatric surgery. And first, I'd like to introduce my co-moderators. First, Dr. Kunoor Jain-Spangler will be joining me this morning from Duke University. And in the afternoon for the West Coast rebroadcast, we'll have Dr. Matt Martin, who I will be joining also. I am really excited about today's speakers and today's topics, but before we introduce them, I'd like to make a few announcements. First of all, I'd like to remind everyone to use the Q&A function of the Zoom application for your questions. We like to make this interactive, so please go ahead and enter your name, your institution, and the question, and we'll try to get to as many as possible. I also want to announce next month's topic, which is going to be psychological issues in bariatric surgery, not only in the preoperative bariatric evaluation of patients, but also the long-term psychological consequences and issues that bariatric patients have. And we are also excited to have wonderful, wonderful faculty for that. A few other reminders regarding the Fellow Project. We'd like to remind everybody our mission to unify didactic efforts across the board and across the world for bariatric surgery fellows. We want to make sure that the objectives of the ASMBS Bariatric Surgery curriculum are touched upon not just once, but several times throughout the year. So as you apply for your ASMBS Certificate of Additional Training, watching these videos either live or on the archive will satisfy those requirements. In addition to that, for program directors, Fellowship Council program directors, it's a way to satisfy the requirements and have proof of didactic and academic activities for the fellows throughout the year for your recertification. I'd like to also remind everybody that if this does not fit in your schedule, or some of your co-fellows or co-faculty are interested and are not able to attend live, these lectures are also available and have recently been archived on the ASMBS Video Library Archive. And that's a wonderful, wonderful tool for our fellows, because as you log on to view these videos, you'll also find about 300 well done, highly edited and informative and educational videos for really important and interesting situations which you may encounter during your practice. And that's just a fantastic tool and an option to augment your educational experience as a fellow, particularly in a time where there are potential slowdowns and shutdowns due to the pandemic. In addition to that, I do want to plug for program directors. If you're a director, or associate director, faculty, coordinator, this Saturday will be the Fellowship Council Program Director Summit. There's already several hundred registrants. It will review and discuss, it's a forum to discuss many of the issues that affect not only us as educators, but our fellows during these tumultuous times. And I know myself and Dr. Ann Rogers will be joining us today. We both will be participating as speakers in that forum. And finally, on a sad note, I do want to let the fellows know that we lost another giant in the world of bariatric surgery, Dr. Nicolas Kunoor, who was a forefather of bariatric surgery and a pioneer in developing the biliopancreatic diversion, which subsequently was modified to the duodenal switch and more recently to the SADS, passed away within the last week. And he is somebody whose loss we're mourning and a great loss to our community. And I would encourage you, if you have a chance and haven't seen our September edition, which did review the BPD DS and the SADI procedure, to review those and learn a little bit about some of the work that Dr. Kunoor did as he paved the way for what we do today. So with that being said, I will move on to today's topic. We are going to discuss some pearls. Many of the perioperative pearls in bariatric surgery. We're thrilled to have a couple wonderful, wonderful lecturers. We have Dr. Ann Rogers. Ann really needs no introduction. She's very well known in the world of bariatric surgery. She has had numerous leadership positions in the ASMBS and has led many committees. Currently, she's the liaison of the Clinical Issues Committee and the Pediatric Surgery Committee, and serves on the executive committee of the ASMBS. She's been a prolific force in the world of bariatric surgery as an educator and as an author, where her name is synonymous with many of the research interest in gut and brain hormone changes in bariatric surgery, clinical outcomes, as well as quality improvement. So thank you, Anne, for participating in this. And in addition, we also are pleased to have Dr. Julianne Lloyd, who's Assistant Professor of Surgery in the Michael E. DeBakey Department of Surgery at St. Luke's Hospital in Houston. Looking at Dr. Lloyd's path to this position, it's incredibly impressive, with undergraduate studies at MIT, followed by medical school, Johns Hopkins, residency at the Cleveland Clinic, and culminating with fellowship in minimally invasive surgery and bariatric surgery at the University of Pittsburgh Medical Center. And Julianne is a dedicated researcher and educator, and she has a research interest in the pathophysiology of obesity. And I'm thrilled to say that she's our most recent addition to the Bariatric Surgical Training Committee of the ASMBS. Thank you, Julianne, for joining us today. So we're going to start with Dr. Ann Rogers, who will be speaking on a very important topic. We all tout PE, VTE, DVT, and coagulation problems as the number one most common potentially preventable cause of death in bariatric surgery. And there should be almost uniform consensus as to the prevention, treatment, management of these conditions, yet there is not. But Dr. Rogers is going to try to bring some light to these conditions and tell us what the current literature says and what we should be doing from a clinical standpoint. And we will follow that up with Dr. Lloyd, who will review a lot of the perioperative pearls that are intended based on evidence in the literature to improve perioperative outcomes and long-term outcomes in bariatric surgery. So I think I've said enough. Thank you all for joining us today, and we'll turn the podium over, the virtual podium, to Dr. Rogers.
Thank you, Adrian. I hardly know myself from that introduction, but I appreciate it. So as Adrian said, I'm at Penn State. I run the Penn State Surgical Weight Loss Program. I'm co-director of our fellowship. I'm going to talk about a couple things, primarily VTE prophylaxis, and then a little bit about cardiopulmonary optimization. Let's see. So just keep this picture in mind. There's a kid, 25, died of internal bleeding after a cut price weight loss operation in Turkey. My disclosures are that I am a proctor for Intuitive Surgical, but this will have no bearing on my talk today. So part of the reason that Adrian asked me to speak on this is that I have been involved in all of the position statements that ASMBS Clinical Issues Committee have written on VTE prophylaxis in bariatric patients. The original statement came out in 2007 when I had first joined the committee. We then updated it in 2013, and it's actively being updated as we speak. And there is a draft that's nearly ready for dissemination, and I decided to take this opportunity to give you all some of the summary recommendations from that draft that's being written. The lead of that writing group is Ali Aminian at Cleveland Clinic. So the first thing is that post-op VTE is actually extremely rare, but it can significantly increase morbidity and mortality in bariatric patients. And I think there was a time that this was the #1 cause of death in bariatric patients, and it has probably gone down because we do take steps to prophylax against it. Almost all bariatric patients are at least moderate risk. So that person who looks young and healthy with a BMI of 35 is still at moderate risk. And many of our patients are either high risk or even extremely high risk for VTE. Some of the things that increase your risk for VTE include the higher BMI, advanced age, male gender, immobility, a past history of VTE, other hypercoagulable conditions, heart failure, pulmonary circulatory disorders, venous stasis, hormone therapy, which many of our patients are on, longer OR time and open surgery, which we try to avoid. And then the occurrence of any other postoperative complications then increases a patient's risk of having VTE. So first of all, you should consider the peri-op discontinuation of any hormonal therapy, if at all possible, well before and for a while after bariatric surgery. All bariatric practices should develop and then adhere to some sort of VTE protocol. This is one of the required things that you have to have as an MBSA-QIP accredited program. And again, it has to balance thrombosis versus bleeding. And I think most people would prefer to deal with a bleeding episode, which is something that can be treated with anticoagulation and transfusion and reoperation, as opposed to a saddle embolus that just comes along and kills you dead and there's nothing you can do about it. So these protocols should probably all include early ambulation, mechanical thromboprophylaxis, and chemical thromboprophylaxis for most, if not all, bariatric patients. And even when you have a protocol like this, it may reduce but still not completely eliminate the risk for VTE in our patients. So most of these events do occur after discharge. And so it's now recommended that some group of patients may benefit from extended post-discharge pharmacoprophylaxis. We do this in our program. All of our patients go home with 2 weeks of low molecular weight heparin. Higher risk patients go home with 4 weeks. And I see a lot of this happening as an MBSA-QIP site surveyor, although I was telling Dr. Dan that I've been to many programs where all they do is put on SCDs for the case, and then that's all the patients get, which I find surprising, but there is really no high quality data on this because we have not been able to commit ourselves to a randomized prospective trial. And that's why we don't have the best data. We don't have the best data on which agent to use, how to dose it, how long should be given. It's unfortunate. Just know that it probably should be given. The highest quality data supports using low molecular weight heparin. It seems to be more effective in bariatric patients than unfractionated heparin. It's got better bioavailability and lower risk of heparin-induced thrombocytopenia without also increasing the patient's bleeding risk. If patients have renal insufficiency, they should probably get a reduced dose of low molecular weight heparin or have the dose adjusted based on anti-factor Xa levels, or to go ahead and use unfractionated heparin in these patients. Otherwise, low molecular weight heparin is usually recommended with a fixed dose for patients, or at least BMI tiered dosing, meaning one dose for patients with a BMI of 35 to 60, and then perhaps a higher dose for patients with a BMI over 60. And it is possible to adjust doses based on anti-factor Xa levels. However, we don't know the best target anti-10A levels. So some programs do check these, and there are sort of recommended ranges for anti-10A, but nobody really, because it is now such an unusual problem, nobody knows what the best level is for most patients. The routine use of vena cava filters is not currently recommended. They are invasive. They require an invasive procedure to place and to remove if it's a short-term filter. And so the complications related to filter use really seem to outweigh the potential benefits. However, they should be considered for some of the very high-risk patients where the risk of VTE is greater, where there are some patients who have such limited lung capacity, if they get a single pulmonary embolus, they're not going to survive it. So these are patients where you might consider using a vena cava filter along with other things. So now Adrian asked me to talk a little bit about how exactly the Clinical Issues Committee develops these statements and guidelines that we come out with. And it actually is a fairly agonizing process, but it all starts with an idea. And ideas for these statements can come from members of the committee. They sometimes are passed down to us by the executive council. They may be suggested by other professional organizations who we work with, and sometimes they come from patients who actually ask us to address certain issues. So once a year, the Clinical Issues Committee puts out a call for statements to the entire membership, and we get lots and lots of recommendations for things that people would like to have guidelines for. And we usually have to pare that down to 5 or 6 statements per year, and we send those to the executive council, who then determines which topics we will write on. After that, when we have a set of topics, the clinical issues chair requests a set of volunteers and a leader for the writing group of any given statement that's going to be written. Then there is a massive updated literature search, and we're very lucky to have the help of a lady named Kara Callies. She is a consultant that we use to do all of our literature searches probably for the last 10 years or so. She works at the Gunderson Clinic, and that has been incredibly helpful so that we do not have to take a lot of time, pouring through the literature to find out what's new in any given topic. So with that literature search, the lead of the writing group creates a draft of what will be written on, and then they meet with the working group and assign different topics for the statement. So each person in the working group can focus down on a subtopic for the statement. And then a timeline is set for writing. And if things go according to plan, it usually takes 2 or 3 months to come up with a draft that's put together by the writing group. The first thing that happens is that initial draft is then sent to the full Clinical Issues Committee for comments. And this is a process we usually give about 3 weeks for people to review it and send back comments. After that, if the committee seems happy with the draft, it is sent to ASMBS's legal department for review. And it's possible to put things in a statement that make it sound like this is what everyone must do. And we really don't want to do that. We don't want our statements to be something that can be potentially used against a bariatric surgeon in a court of law. We do the wording such that these are guidelines, recommendations, a review of the literature, but not definitive, you must do this. After legal comes by, then this draft is sent to the executive council, and they have a little bit of time in which to review that draft. And generally, it does not pass through the first time it goes through the EC. Except for me, there's a bunch of smart people on the executive council, a lot of past presidents of the organization, and they have a lot of knowledge and often will send the draft back to the working group asking for revisions in certain parts. When it finally does get approved by the executive council, it then goes out to the full membership. So everyone who's a member of ASMBS, both physician and integrated health, has an opportunity to review these drafts. And again, we give about a 3-week period for commentary. And then the chair of the Clinical Issues Committee responds to every single member comment in writing. And that's no small job. We get a lot of commentary about these things. And sometimes it's thank you so much for writing this, but a lot of times it's dissent, or it may be asking for us to add a new manuscript that we hadn't been aware of from the original literature search. So based on this, the lead of the writing group makes the necessary edits, and then the chair of the Clinical Issues Committee then decides if it needs to go back to the full committee for review. After that's happened, the newly revised draft is again sent to the Executive Council for final approval. Generally speaking, they finally approve it, and then once it is approved, the manuscript is submitted for expedited publication in SWORD. Now, these guidelines and statements are usually reviewed on an every 3-year cycle, but as needed. Sometimes new data comes up in just 1 year. I had the luck of updating the SADI statement when there was a push to have this be an endorsed procedure. And within a relatively short period of time, there was quite a bit of new literature. But we don't have a lot of literature on this topic, unfortunately, which is why we did feel it needed to be updated with the literature we have, but we still don't have the most definitive way of saying this is what you should do. Now, regarding cardiopulmonary optimization, there is also a lot of literature on this. And the data that we have has been used by MBS AQIP in their determination of designation of different kinds of bariatric centers. For example, their designation of the low acuity patient selection program is such that they should operate only on adults and they have to be under 65. They can operate on males, but only with a BMI under 55 and females with a BMI under 60. And they cannot operate on patients with any organ failure, an organ transplant, listed for transplant, or any other significant cardiac or pulmonary impairment. And the patients have to be ambulatory. So these are pretty strict designation criteria for low acuity centers. Comprehensive centers do not have any such limitations. They can operate on patients who weigh 2,000 pounds. They can operate on patients with paraplegia. Doesn't matter. They just have to be able to show that they have the ability to care for these patients on whom they operate. So it can be the sickest of the sick. But in reality, in day-to-day business of running a bariatric program, often how we optimize patients is driven by insurance. So there are some insurance plans that demand a cardiac and pulmonary evaluation, even on somebody who's 18 and otherwise healthy. And so we go ahead and do it just to get authorization to keep access to care, but it may be unnecessary testing for a lot of patients. I will just say we have to get away from the concept of clearance. You know, it's not the medical doctor's jobs to clear patients for surgery. What we need to do is optimize patients for surgery, and also part of their job is to do a risk stratification of our patients so we can have a more intelligent discussion of the potential risks and benefits of the operation. So there's just a massive amount of literature out there on pre-op cardiac and pulmonary assessment. For instance, this paper looked at a number of tests that they did on all of their patients in a group of about 200 patients. And they were able to break up these tests into essentially 3 groups. The first, those tests that were non-informative. They basically had no value for management, and that included routine stress testing and using the Epworth Sleepiness Scale. The second group of evaluative tests was those that were informative. They were often abnormal, but they didn't have any effect on the decision to operate or what operation to offer. And that included things like routine chest X-ray, echocardiogram, pulmonary function testing, and blood gases. And the third group of tests was those that were both informative and pertinent to avoid complications, and that was sleep studies and EKG. So in a bariatric program, it would not be unreasonable to do routine sleep studies and EKGs on all patients, and that may actually affect your management. The stop bang has pretty much replaced the Epworth Sleepiness Scale. They're both questionnaires that patients answer, and based on their yes or no answers, they're assigned a score giving them lower, intermediate, or high risk for having obstructive sleep apnea. And many studies have shown that the vast majority of bariatric patients have obstructive sleep apnea to at least some extent. There is science behind this, but I'll just say I picked out my top things that people should really be worrying about when trying to optimize their patients. The first being severe critical aortic stenosis. And I think this is a diagnosis where the patient should probably get their valve dealt with before their bariatric surgery. Whereas nowadays we often will offer the bariatric surgery as a route to patients having other medical treatments. But I think if a patient with critical aortic stenosis, if they code, they're not going to be easy to resuscitate. So I know that there are some trials going on now of doing bariatric surgery in valve patients, but probably this should be done under such a trial. Heart failure is another thing. There are many kinds of heart failure, but if patients can be optimized, that really helps. Obviously, anybody who's had a routine heart attack or stroke, like with any elective surgery, should probably wait and get them out of that peri-event procedure. There is new data on patients who have daily oxygen dependence. I reviewed a paper for SWORD not too long ago, and it did show that patients, even using 2 liters of oxygen on a daily basis, have a much higher morbidity and mortality after bariatric surgery. So something to consider. And then untreated sleep apnea. This is probably why we should test most, if not all, of our patients, because sleep apnea can cause significant right heart strain, and patients who have not begun to have it treated are probably sicker than patients with untreated diabetes. They're at severe risk for stroke and heart attack. So it should be treated early, and their compliance should be tested if patients have severe sleep apnea. Left ventricular assist device patients, again, these would not be done in a low acuity center. We have a number of these patients that we've operated on. They tend to be younger people, but with obviously a heart that doesn't work. They tend to be on anticoagulation, and they also tend to have tubes and drive lines that are in really inauspicious areas for a routine operation. So people with these issues probably ought to really try to get optimization and be dealt with in a high volume center. Now, regarding specifically the pulmonary evaluation, I mostly focused on the heart previously. This was a study that looked at some risk factors for acute respiratory failure in non-cardiac surgery, and looking at upper abdominal procedures, which is most of what we do. Those patients got a score of 21, which put them in a risk category of about 4% risk of patients undergoing bariatric surgery ending up with acute respiratory failure. And that seems kind of high to me. If we think about our routine patients that we do on a daily basis, it's unusual for them to suffer acute respiratory failure, but it just shows you that we are optimizing patients in our programs, and that's probably why this number seems a little bit high. If you're worried about your patients, there's a number of risk calculators that can be used, including the NSQIP surgical risk calculator. There is a specific bariatric risk calculator that MBS AQIP provides, and these are useful things to run through with any given patient to let them know, yes, I understand you are at risk, and this is what we have done to optimize your risk. And if we can get you through this safely, you're then going to be at less risk for problems going forward. So probably the final most important thing that I find helpful is to have a dedicated anesthesia team, particularly if they are committed to data-driven care. That they're familiar with the issues that are commonly seen with our patients, and at least somewhat versed in obesity sensitivity, because they're meeting with our patients at a very vulnerable time, and it's helpful for them to be on the same page with us. So with that, I will stop there and I'll turn it back over.
Thank you very much, Anne, for that very informative, wonderful talk. And we'd like to remind our registrants to place your questions in the Q&A portion, and at the end of the entire lecture portion, we will go ahead and address some of those questions. So without further ado, I'm going to turn it over to Dr. Julianne Lloyd, who will talk to us about other perioperative pearls in bariatric surgery aimed at improving overall outcomes. Julianne, take it away. Thank you.
Sure, just give me 1 second. Let me share my screen with you guys. Good morning, everybody. I would like to start by thanking Dr. Dan and the committee for the opportunity to present to you guys. I hope that you find this very helpful and you guys learn a lot from this. So I have no disclosures. I'm actually going to cover a number of topics, which honestly, each of these could really be their own lecture, but we'll try to get through them. So the first thing to look at is marginal ulceration after bariatric surgery. I would say this is probably the Achilles heel of the gastric bypass operation. It's the most feared complication after leak. It's something that typically occurs on the jejunal side of the anastomosis. The incidence has really been around 1 or 2%, but reported in the literature, I've seen up to 25% of cases. And the presentation is pretty variable. So about a quarter of the patients typically are asymptomatic, but others might have epigastric pain, dysphagia, nausea, and vomiting. And rarely they may come in with GI bleeding or perforation that requires emergent operative intervention. But of note, the time to diagnosis is also very variable. And so for all of these patients post-operatively, I would keep the marginal ulceration on the differential diagnosis when you see them complaining of abdominal pain and GI symptoms. The pathophysiology is really not very well known. It's considered to be multifactorial, and there have been some risk factors that have been identified, primarily associated with ischemia at the site, but it could also be the presence of a foreign body or any kind of situation that really creates a caustic environment in the area. So we always know to ask our patients about their NSAID use and about smoking, because these are probably the top 2 risk factors in this category. And these are known to not only promote the formation of ulcers, but they also inhibit the healing as well. So how do you prevent patients from developing this complication? And I'm using that term loosely. The first thing is really to avoid offending agents. So we always caution our patients against using alcohol, soda, caffeine, just in general. But really to go back to the top 2 I had mentioned, NSAIDs and smoking, I think at this point we should really be cautious about determining what's the best operation for each of our patients. And so there was a study published in the Annals of Surgery within the last year that actually looked at smoking history before gastric bypass. And they showed that while smoking cessation counseling is pretty effective, you can see that actually the number of smokers or the number of smoking decreases just before surgery. There is still a high relapse rate over time, especially for patients who are smoking within a year of surgery. And so for these patients, I would actually consider steering them more towards a sleeve as opposed to a gastric bypass, because they are going to be considered high risk for the latter. Similarly, for patients taking non-steroidals, I would try to transition them off these medications ahead of time. The one exception is probably baby aspirin, or the 81 milligrams of aspirin. There are lots of patients who are taking this medication for cardiovascular protection. And fortunately, the low dose aspirin has been shown to have no increased risk in terms of marginal ulceration. You can see here, it's not statistically significant. However, for these patients, I would actually keep them on prophylactic PPI, and I would consider doing that indefinitely, so lifetime treatment. And so that takes us to the fact that there is unfortunately no consensus regarding not only the use, but also the duration of these acid-reducing medications. I know most surgeons at this point are either using PPIs or H2 blockers, and they generally treat patients for about a month to up to lifetime after surgery. We do have some data that support its use. And you can see this study that was done with bypass patients showed that PPIs for 6 months actually does decrease the marginal ulceration rate significantly. It was shown to be an independent protective factor. And in fact, it also decreases just general GI complaints from patients, not just the marginal ulceration rate. So I think this really supports its use. But again, we don't have much data on how long to treat patients. I think in general, looking through the literature, it suggests that longer duration is better. So do our patients really need 6 months, as a previous study shows? It's unclear. But in comparing 30 days versus 90 days, you can see that there is a statistically significant reduction for patients who were treated for a longer period of time. And this is looking at ulceration within the first 2 years of surgery. I would say in general, it's probably best to treat patients with PPIs. Currently in our practice, we had been doing 30 days. Now we're moving more towards the 3-month mark to treat patients. So let's switch gears and talk about gallstones. So you guys will remember from medical school that being obese actually increases your risk of developing gallstones. You'll remember the 4 Fs. But actually, not only that, if you have rapid weight loss, whether it's from bariatric surgery or from diet and exercise, this can also be lithogenic in patients. And so what happens in the pathophysiology is that you have an increase in cholesterol secretion, you have a decrease in bile secretion, and there's also bile stasis. And so Actigol is a medication that we have been using traditionally to help reduce gallstone formation. This is the ursodeoxycholic acid. And it works by dissolution of the excess cholesterol that's present. And it has been shown to actually reduce the need for urgent cholecystectomy after surgery. But I would say the biggest issue is really compliance in patients. They have lots of side effects, which actually the late great Dr. Sugarman had demonstrated that if you do BID dosing, so divided doses, patients actually tolerate it much better. But they still have to add another medication to already a long list, and it might be expensive. And if they're taking the capsules in particular, they have to break this open and the contents taste really badly. So there are lots of reasons that patients don't want to take it. Currently underway in the Netherlands, there is a trial that's actually looking at defining the specific benefits of taking this medication, and hopefully based on the results, we'll know for sure whether we should definitively add this to the list for patients. The second clinical question about this is whether or not we should be removing the gallbladder at the time of bariatric surgery. So I guess the short answer is we really don't know. So on the one hand, there is the risk that if you leave the gallbladder in situ, then you may end up having biliary disease after surgery. And for patients who have, for instance, a gastric bypass and they develop CVD stones, it's very difficult to get to the common bile ducts. They may require transgastric ERCP or push enteroscopy. But on the other hand, there are data that show that by removing the gallbladder at the same time as bariatric surgery, then you've increased the operative time and also increased the peri-op morbidity. The general trend right now is to be more conservative and really only remove the gallbladder at the same time as doing bariatric surgery if the patient is significantly symptomatic at the time of surgery. All right, let's talk about post-op diets. So I would recommend that you guys check out the ASMBS website. They have their guidelines listed on there, and they're incredibly informative and helpful. I can show you guys what we do in our practice, and I know there's lots of variations in how people manage the diet afterwards. I would say the one common theme is that patients should really be evaluated ahead of surgery by a dietitian, and the whole diet progression should really be overseen by a dietitian afterwards. So what we have been doing is about 4 hours after surgery, we start patients on clear liquid diets, and this is with low sugar clears. We focus primarily on getting adequate hydration, so they have volume requirements, and also getting adequate protein. And so the day after surgery, we would typically advance them as long as they're tolerated to full liquids, and then they would go from there to soft foods. So again, this is something that the nutritionist has to oversee. I would say there are additional considerations as well. The biggest thing I cannot stress enough is for you guys, wherever you end up in practice, one of the first things I would do is check the hospital menu. And not every kitchen understands what qualifies as a bariatric soft diet. And the last thing you want is that you're rounding on patients, maybe in the afternoon or something, and they have a steak on their tray. So I would definitely do this before you start prescribing bariatric diets for patients. And then, of course, in our patient population, this is a common theme. You really have to do a lot of reinforcement with them and a lot of education. So just prepare for that. And this applies generally throughout your entire career, I would say. All right, so I'll just touch briefly on early ambulation. I know Dr. Rogers had mentioned this also in her talk. You guys are aware that early ambulation was really studied as a part of bundled interventions. Most of the early studies were done through colorectal surgery, but we now know that in general, early ambulation decreases length of stay, decreases complications, including DVT or VTE incidents. More recently, there's been a focus on looking at pre-op functional status. We already know that having any comorbidities increases the chance of getting discharged to a facility. But what's been shown in our recent meta-analysis is that impaired functional status is the single greatest independent preoperative predictor. And based on this information, I would actually consider adding, or I would recommend to you guys that you consider adding physiologists to your multidisciplinary team so they can do a good pre-op risk assessment for patients and ensure that they're able to tolerate the surgery and have good functional status afterwards so that they're not being discharged to a facility. So finally, I'll talk about pain management strategies. So we already know that there are changes in the physiology and the metabolism of patients after surgery. They just don't absorb medications as well. They have a decreased mucosal absorption area. They may have increased gastric emptying time. So lots of changes happening. In addition, there are other challenges. So it's difficult to place epidurals on these patients. And, you know, based on the risk of marginal ulceration, we really are trying to stay away from non-steroidals. So how do you manage patients? Well, fortunately, this has been well studied and we have ERAS protocols. So typically when patients arrive at the hospital, they're getting multimodal types of analgesia. So they may get a cocktail of Tylenol, gabapentin, Celebrex, even before they get to the operating room. And then intraoperatively, we're doing injection with local anesthesia. If you are fortunate enough to have Exparel, which is the liposomal bupivacaine at your discretion, then consider yourself very lucky. I would very liberally be using this on the patients. And I'll talk about tap blocks in a little bit. But after surgery, we generally are trying to minimize narcotics, and that's really the overarching theme here. And so we typically keep patients on scheduled Tylenol. And then I do give some Toradol around the time of surgery, but generally not after that. We do offer gabapentin to our patients, and then narcotics are really used as rescue therapy. And then on discharge, we send our patients home on Tylenol and Tramadol, and then again, usually narcotics just for rescue as needed in a small subset of patients. But we always send them home on a bowel regimen. I think that's really important to note because the last thing, again, you want is for patients to show up in the ER with constipation, and that's primarily from their pain medication. So I mentioned tap blocks. I think this is an incredibly useful adjunct to treat post-op pain in patients. It's important when you're doing a tap block to really get in the correct plane, which is between the internal oblique and the transversus abdominis. When we were in residency, I remember one of my attendings would always say, you want to look for the goose egg, like create the goose egg. And so it really is not an injection in the subcuticular space or in the subfascial space. You really have to get it in between the two muscle layers. It's pretty effective. And actually, a multi-center trial demonstrated that it is superior to injecting just local anesthesia in terms of early pain control, and that's both for patients at rest as well as with motion. It is comparable to the ultrasound guided taps that the anesthesiologist might be doing for us before or after surgery. But honestly, when you're in the operating room, you're already intra-abdominal and you can see the peritoneum. I think it's a very good time to apply a tap And I will also use it subcostal sometimes because I use the Nathanson, and patients don't really complain about pain in that site afterwards. I think anecdotally it's very helpful. And then there is another subset of patients that really warrant discussion. And it's those who are taking chronic opioids. And I really want to focus on this because, you know, we're in the middle of an opioid crisis. I was surprised to learn that as many as 50,000 people die just from opioid overdose. So I would caution you guys to really think about this stuff as you start taking care of your own patients. But the CDC defines chronic opioid use as anything more than 3 months. And if you look at the data for the bariatric population, you can see that we have about fewer than 10% of our patients are actually taking chronic opioids. And this might be for fibromyalgia, osteoarthritis, they may have degenerative joint disease. So they have issues that really warrant chronic pain control. But what's really concerning is that you have such a large portion of patients who are continuing to use the opioids outside of the operative period. And there's even increased risk over time. So how do you manage these patients? I would say the biggest thing is really to consult pain management, get them involved early. They will frequently work with patients to come up with a pain regimen, and they'll also come up with pain contracts for patients. The other thing that you want to do is to look at the prescription monitoring programs online. And this is not just for chronic pain patients, but even whenever you're prescribing narcotics for all patients after surgery. There isn't really a national program right now, but there are statewide programs. And you can check them and it will tell you whether patients have been using multiple narcotics and if they've been also shopping around to different physicians. But I think it's a good resource for us, and I would use it whenever prescribing. In general, we're trying to go away from narcotic use in patients. And I think, you know, based on using the ERAS protocols and keeping patients on Tylenol, tramadol, we've been very good at controlling pain after surgery. So that was kind of a whirlwind, just to kind of summarize what we've gone through. So with marginal ulceration, I think it's really important for you guys to focus on procedure selection, making sure that it's the right operation for each of the patients. You want to encourage patients to stay away from the precipitants, so NSAID, smoking, you know, some of the other risk factors I had talked about. And I would encourage use of prophylactic acid-reducing medications right now. It's not clear what's the best way to do it, but I think if you give something for at least a month, then you are offering some kind of protection for patients. With respect to gallstones, I think Actigall is still a good source for us, but of course it's difficult to get patients to stay compliant for the 6 months that's required. You know, hopefully with this upgrade trial, we'll have definitive results at the end of that period to say for sure, you know, what's the best course forward. For all of the patients, we want to emphasize early protein supplementation and of course hydration. But I do start patients on protein supplementation as early as post-op day 1. Of course, early ambulation, as Dr. Rogers had talked about, and I would consider prehabilitation by getting the exercise physiologist involved. And then again, minimizing narcotics just because of the opioid epidemic. And you have multiple different techniques at your disposal, including using TAP, which I think is pretty good. So with that, I'll take any questions.
Thank you, Julianne, for a wonderful review of really the pillars of postoperative management in bariatric surgery. I know it's a huge topic, but you've done a wonderful job of reviewing those main principles. I'm going to turn it straight over to Dr. Jain-Spangler, who's going to moderate some of the questions that are coming through already.
Kunoor? Thank you, Dr. Dan. I just want to echo that. Those were both fantastic talks. And we do have a couple of very interesting questions. The first, I believe Dr. Rogers touched on this. If Dr. Lloyd also has some comments, we'd be happy to hear them. Is there a certain amount of time we should wait after the diagnosis and treatment of sleep apnea before proceeding with surgery? Can patients get their machine and then be scheduled for surgery the next week?
Sure, they can. The question is, should we do that? So we know pretty well that, for instance, smoking cessation should happen more than 6 weeks prior to surgery. And so if you quit a week prior to surgery, you're actually going to increase your complication rate. So things like smoking, we know definitively. I will say that getting your CPAP machine is not the same thing as using it. And so patients with severe sleep apnea should probably be tested for compliance. Now, there are some studies that show the first night of use, just one night, decreased sleep disordered breathing significantly, and it also decreased arrhythmias the very next day. So even just one day of use starts to really help. But patients who are new to using CPAP have a getting used to it period, and insurances that cover the machines and all the equipment usually allow change outs every 2 months. So I would say a period of 1 to 2 months is probably not unreasonable for a new CPAP user to be sure that they're actually able to use it.
Great, thank you. Another question, and I think we all struggle with this. Our pharmacists did a pretty extensive review on this and also came up with the conclusion of there's no great answer. But it is compliance with Lovenox or heparin injections was an issue in my residency program. Based more on tradition than evidence, patients were given 1 milligram of Coumadin daily for 1 month after surgery. The MBS AQIP bleeding and thrombosis complications were comparable to other programs. Has there been any research into oral VT prophylaxis, antiplatelets, Coumadin, novel anticoagulants for sleeves, etc.?
Yeah, there's some. Well, it helps that now we have reversal agents for these anti-factor 10A meds. So I've taken to letting patients go home on some of these oral agents if I'm fairly certain that I've gotten them past the point that they're likely to bleed. But then again, they're more expensive. So I think a lot of adherence to medication regimens is not just the needle, but it's the cost. But either way, we don't even know if patients are not only giving themselves a shot, but taking a pill. But I would say 1 milligram of Coumadin is almost like sprinkling somebody with pixie dust. And so I would say if you're going to do that, don't do anything at all. But stick to the things that work. There are a lot of studies, but nothing has yet been shown to be the best agent.
Thank you. A couple for Dr. Lloyd. Is there a specific bowel regimen recommended for constipation?
Sorry, I just realized I had muted myself afterwards. Not as far as I know. I would say in general right now, it's probably best to give something that the patients will tolerate and will be compliant with. So what we have been doing is using one of the more inert substances. So that's like Miralax. For some patients, I actually do recommend taking Colace preemptively. So I put them on Colace daily. But I think as long as they're taking something, it's better than not.
Yeah, also definitely recommending an increase in water intake is always key. Is there any data on the effect of passive smoke exposure on the risk of ulcer formation?
Nothing that I've seen. And actually, that's really interesting because I do have patients. So I actually check for all of my patients who are smoking within a year of surgery. I do a nicotine test on them. And if the test comes back positive, then that's something that we discuss in clinic and then come up with a plan. And you can see patients who report having passive smoke exposure actually do have a positive nicotine test. And I think that is the big difference in terms of the marginal ulceration rate. So really, it doesn't make that much of a difference whether it's an active or passive smoking. I would definitely encourage patients to stop. So smoking cessation counseling is important. And again, just making sure that they're not too high risk for one of the bypass operations.
Thank you. Chronic steroid use increases risk of marginal ulceration. Do you extend the prophylaxis more than a month if they're on a small dose of steroid? That's a great question.
Yeah, so for those patients, I actually do keep them on lifelong like acid reducing medication as well. So that was the one thing I guess I didn't mention early on. But for patients who are taking a baby aspirin and for those who are on steroids, but again, for the steroid population, I even consider doing a sleeve instead for those patients, and if they're good candidates for the sleeve operation instead of doing a bypass.
Awesome. Well, thank you both so much.
Awesome. Thanks for having us.
Yeah, thank you so much, guys.
Thank you very much one more time, Dr. Rogers, Dr. Lloyd, for very informative and wonderful, wonderful lectures. Our fellows are sure to benefit from these. I'd like to end by saying join us next month for psychological issues for bariatric patients. And also, if you are a director, associate director, faculty, administrator, coordinator, the Fellowship Council Program Directors Summit is tomorrow, and it's a wonderful program organized by Dr. Shan Kothari, and I look forward to seeing you all there. Otherwise, we will see you next month. Thank you all.
Thank you.
Hey, this is Matt Martin, Scripps Mercy Hospital. Happy to moderate this afternoon session. Let me start by thanking Dr. Rogers and Dr. Lloyd. Those are two fantastic talks, and I think we have both of them online. I see Dr. Lloyd. Can you hear me?
I can hear you. Can you hear me?
Yeah. How about Dr. Rogers?
I'm here. It says that the host has to start my video.
Okay, can we start her video, please? We've got a couple questions coming in. Let me start it off for you, Dr. Lloyd. You mentioned, avoiding NSAIDs and maybe using Toradol. So is peri-op Toradol a concern for marginal ulceration, and how are you using it?
So I haven't seen any data specifically addressing that. And anecdotally, I haven't seen any issues in my patient population. Right now, I will typically do within the first 24 hours, I'll give patients Toradol. So basically until they get discharged. But after that, then I absolutely don't give Toradol to any of the bypass patients. And in special circumstances, I'll be willing to give Toradol to the sleeve patients, but it has to be that we're unable to control their pain otherwise.
Okay. How about you, Dr. Rogers? Do you agree with that, using Toradol or not using it at all?
Yeah, it's part of our B-stop protocol, and it's okay. I have anecdotally seen a patient who went into renal failure because she came in dehydrated and then got Toradol. So that, that was a problem, but as long as you can keep patients well hydrated, I think it's probably fine.
Okay. We've got a couple of questions about the DVT and VTE prophylaxis. You mentioned IVC filter that I agree we should be using sparingly. Is there anybody now that you are still using IVC filters on, or what patient would that be? Dr. Rogers.
It would really be somebody who had already had numerous PEs and had restricted lung function, most likely, who was not going to be able to tolerate one more, basically.
Okay. And so no role for prophylactic communicable filters?
Not anymore.
Okay. And then a bunch of questions about some specifics of the VTE prophylaxis regimens. So let me just ask, what you're doing now. I'll give you a couple patients. You have a BMI 35, no other major medical problems, undergoing laparoscopic gastric bypass. What's your pre-op and post-op preferred regimen now?
So we basically do 3 tiers of dosing. For people with a BMI of 50 or greater, they get 60 milligrams of enoxaparin. For people with a BMI of 40 to 50, they get 40 milligrams. And for people 35 to 40, I give 30. And they get 1 dose preoperatively, and then they get it Q12. And that is continued for most people for 2 weeks post-op.
Okay, so you're doing BID dosing. Now, what about patient, again, BMI 45, but has chronic renal insufficiency, creatinine of 2.5?
Yeah, we'd probably either do once daily dosing or maybe do unfractionated heparin.
And what are you doing for unfractionated heparin in these patients? Are you 7,500 TID?
No, we're doing 5,000 TID.
5,000. Okay. Dr. Lloyd, a couple questions about smoking and nicotine use. What's your requirement for your patients for smoking cessation before you'll do surgery? And are you testing for nicotine pre-op?
So minimum 6 weeks cessation prior to surgery. And we do test. if the result comes back positive. So we do a cotinine test. If it comes back positive, then I'll have the patient back in clinic, or I guess now through telemedicine, and we'll have a discussion about why it was positive, and really what's the way moving forward. For me, it's kind of a hard stop. You have to stop smoking before surgery. I recently had a patient who was positive because of passive smoke exposure. And that's something that we also try to avoid, because it will turn the nicotine test positive as well. But it's kind of a hard and fast rule for me.
Okay, and then you know, the data you showed is, you know, pretty concerning about the recidivism rate.
Mm-hmm.
So does that give you any concerns? You know, you have a patient who quit for 6 weeks. I guess after that data you showed, I'd still be pretty concerned that, you know, 30 or 50% of them are going to be smoking again pretty quickly.
Yeah. So honestly, that's why I was saying, if I have a patient who smoked within a year of surgery, so usually by the time I see them in clinic, if they're still smoking, I automatically start to favor a sleeve for that patient instead. You know, obviously it's not it's not black and white. So there are multiple different factors that would help us to decide whether the patient gets a sleeve versus a bypass versus a switch. But already it just makes me super concerned in patients who are still smoking by the time I see them on the initial consultation. And I'm very hesitant to do a bypass in them.
Sure. And Dr. Rogers, how about your program for smokers, and do you test?
We test every patient that enters our program. So everybody gets a NICOT and cotinine level upon entry. And then they have to prove themselves negative before they can even get scheduled for surgery. And then they get tested at a point of care testing on the day of surgery, and they are canceled if it comes back positive.
Okay. And Dr. Lloyd, question here from Mary Chandler. Do you give celecoxib before surgery? And if so, how long before?
We do. So we give just the one-time dose when the patients arrive to the pre-op area, and that's it.
Okay. And then another question from Quindell Jones. What's the maximum dose of Toradol that you're using?
I'll do 15. So it's almost like a baby dose.
So 15 Q6 for 24 hours?
Yeah, until the patients leave. So
okay. Dr. Rogers, do you see any role, especially since you are probably the most up to date on the literature doing the guidelines, any role for the DOACs for either pre-op or post-op VTE prophylaxis, any of the new oral anticoagulant agents?
Yeah, we had talked about this earlier. I actually have one patient that I recently sent out who was higher risk, and I was going to put her on 4 weeks of post-op Lovenox. And then it occurred to me that there was no reason to torture her with that. So we did about a week of Lovenox, and then we switched her over to Eliquis. So now that we have a way to reverse it, I don't think there's any problem with that once we get them out of the acute period.
So do you think we're going to be going to that routinely, or replacing a lot of our?
Well, they're more expensive. So maybe when they're generic, that might be something that we do more of. You know, a lot of insurances just simply won't pay for it. So that becomes an issue. And okay. I have to say that the tiered dosing of Lovenox that I was talking about before, that's not what's in their package description, because they only have dosing really based on your typical 70 kilogram human being. And they themselves say that they don't have any good data on efficacy and safety in patients with obesity, although even that's everybody now.
Sure. Any concerns about the oral absorption of the oral anticoagulants? I don't know if I've seen any data on that in bariatric surgery patients.
I think they're absorbed pretty normally. Coumadin is absorbed normally even in bypass patients. I think most of these agents are absorbed absolutely normally.
Okay. And just to get a different opinion from different center, Dr. Lloyd, what's your preferred VTE prophylaxis regimen? Pre-op, post-op, and then are you discharging patients?
Yeah, so we're using Lovenox. Well, actually pre-op we do sub-Q heparin. So 5,000, just the one time in the pre-op area. And then post-op we're doing Lovenox primarily with BID. We use the Cleveland Clinic calculator to determine if patients need to go home on 2 weeks versus 4 weeks, or maybe nothing at all. We have not really been using the oral anticoagulants.
Okay. And so you're sending them home with 2 weeks of BID Lovenox dosing?
If their risk is high enough based on the calculator.
Okay. Question for Dr. Rogers from Jur Salaber. What about the use of anti-embolism stockings together with Lovenox?
Yeah, I was actually trying to type an answer, but I couldn't make it work. We actually just use serial compression devices, and I think it's just because they seem to be more physiologic than just compression stockings.
Are you discharging the ones you're sending home with Lovenox? Are you discharging them with compression stockings also, or just the Lovenox?
No, because they wouldn't have the machine. So we just tell them, keep walking, keep drinking, keep moving, kind of like the same exercises you would tell somebody to do in a plane.
Sure. Okay. Dr. Lloyd, questions about gallstones, and are you screening everybody for gallstones? And if so, how are you using that data?
So I'm actually not screening. Typically when patients come in, we just have a general conversation with them about any GI complaints. But I don't specifically ask if they've had symptoms, related to gallstones or if they have a history of gallstones. Like I had mentioned before, if they are severely symptomatic, if it comes up, then that's something I will consider discussing with them, potentially removing the gallbladder at the same time, but it hasn't really been a major theme in the practice.
Okay. And then are you using Actigall?
So it's funny because I used it all the time during training. And then in fellowship, we never used it at all. And now I'm in practice and I'm actually not using it. So I think, based on the data, it would suggest that maybe we should try to use it in patients, but it's just so hard to get them, to take all of the medications that they need to take. And I would rather have them focus on taking their blood pressure medicines, taking their diabetic medications, and taking their vitamins, and then worry about the other stuff, like specifically the Actigall later on.
Yeah, I agree. We never really used it in our practice. How about you, Dr. Rogers? Are you using Actigall at all?
I do not use it because I don't believe people would take it, but I've actually studied my own population, and over a couple thousand patients, it's really about 5 to 10% who develop symptomatic gallstones. So it's not common enough, and I tell patients, just to look out for it. And I must say, it's painful to have to do a transremnant ERCP, but we have the capacity to do it, so that's what we do.
Sure. A question on your pre-op evaluation, Dr. Rogers, and actually we'll end with this question. Does that influence your choice of operation? So when they come back with some cardiac or some pulmonary issues, does that influence the operation you choose or recommend?
Really not. I am doing a lot more sleeves than bypasses. And for the patients that then need further weight loss, I'm trending more towards the switch or SADie procedure. So I'm using the bypass more as a revisional procedure mostly. And there is a lot of that. But for first-time bariatric patients, I'm mostly reserving that for people either with unrelenting heartburn or with Barrett's esophagus.
Okay. All right. Well, we're a little past 1 o'clock. I want to thank you both. Those were fantastic talks. I know all the attendees got a lot of great information out of it. We'll thank the ASMBS again for sponsoring this program. And we will see everyone next month. And I believe the topic is on bariatric endoscopy.
Okay.
All right.
Thank you.
Thanks, everyone.
Great. Thank you.
Take care.